Hi, everyone. Welcome back to the podcast. Welcome all new listeners, and welcome back to those who have heard my content in the past. If you want to know when is it essential to use taping and bracing for an injured athlete, you need to tune into this episode. Before I go on to the podcast, what is new? What is better in life? If you listen to my last few podcasts, it has been a rough holiday, rough winter, just with family illness and extended family and friends. But we're always trying to see the positive. Life is great. I was in Ohio for about a week and a half. For those who don't know, I did my residency at the Ohio State University. And I married the woman of my dreams, my wife Stephanie. She is from a small town outside of Cleveland, Ohio. So we go there to visit, and I enjoy the small town, uh, just the small town feel. I love going back, and it's just very refreshing to get some time away, be with the family. It did not snow, for those who are asking. It was pretty cold. I think we were in the 40s, but no snow. So it was good to get away and a little bit of a reset going into 2024, coming off of the last podcast. If you listen to that, but other than that, my kids are great. My daughter today just asked, "Dad, can I start playing the piano?" So we're gonna navigate that and see if that's something up her alley. Let's see what else we got her in soccer. My kids are doing fantastic. My son Jacob, if you guys don't know, my he's about 2.5 years old, and that kid's vocabulary is just skyrocketing. We actually loved it when he was nice and quiet too, but now he is a talker. So family's all good, good reset, and back to the journey. So let's go into this podcast. So, why am I talking about taping and bracing? This is usually like I don't know if I would tape. I don't know if I'd brace. This is a topic that most people are like, I don't think you need it. And as sports PTs, typically you're like, well, what's the research say? What's the best for the patient? I don't like to tape. I don't like to brace because I don't want them dependent on these and this and that. And this podcast is really about to stir the pot for those who are true believers in, or net, non tapers, non bracers. We are going to go into when it is essential, or at a high probability it's going to help this person recover. And we are going to go through this with injured athletes and different scenarios, and what benefit this brings them, and why you might be wrong in what you're doing when you're missing out and not applying taping or bracing. So we'll go through that today. Why am I doing this? Is because I just got off a fiery, huge first module of my sports PT Kickstarter. For those who are in the course listening to this podcast, I appreciate all of you, and I hope you walked away from that module like ready to conquer the world on the next day in your clinical practice, and figuring out which one of my patients can I apply this stuff to. So one of the things that we talked about was in the acute injury phases, when do you tape, when do you brace? And in your clinical practice, I'm gonna take a step back and I'll explain how this all relates to, like, maybe you don't see those type of patients or whatever it is. I'm gonna help you find there's a percentage of the patients you work with or athletes that you work with that would benefit from this, and you might be missing out. And I'll talk about a couple different regions and the types of braces that you might use as soon as next week. So let's talk about breaking down, types of PT scenarios that you would see. And I'm not going to talk about just regions. I'm going to talk about when you see people along the spectrum of tissue healing timelines. Now, why is this important? After this first module of my Kickstarter, we covered truly acute injury management, and it's not very common for sports PTs or physical therapists who are interested in sports PT to manage these type of cases, right? I mean, very rarely. I mean, if you're typically in a traditional orthopedic setting. You may have a patient get hurt. They went to the urgent care, they went to an ER, then they went to their primary care, then they went to a specialist. And by that time, it's 3 or 4 weeks in, and then they schedule an appointment with physical therapy, and that takes 1 or 2 weeks. So by the time you see them, it's about 4 or 6 weeks after their injury. Now, every one of you may have a different scenario, and I completely respect that. But I'm just saying that's a reasonable timeline for a patient to see you. If you are connected with an urgent care, or you're connected with a primary care physician or a surgeon, or you run a direct access, you have more direct access patients. Good for you. You might see this more often. But for those who don't and or do, and you're like, when would I? I mean, I want to add more tools to my toolbox. When is it more appropriate to have supportive braces or supportive things to help this individual? Now, obviously, you don't want them to rely on these things, and you want them to have the good, stabilization and posture and the muscular strength and endurance to be able to do this on their own. Now, there are scenarios where this is an outlier, and you may need this to help get the outcomes that you want. Let's get one thing straight. Our role as sports physical therapists is not to relieve pain. Our role is not to relieve pain, and it's not to improve movement. It is not to get somebody strong. It is not to improve posture. It is not to improve gait. It is not to improve functional fitness. That is not our role. None of that is our role. Those are elements of the main role. But our role is really to help help patients live a healthier, more active lifestyle, right? And for some people, that's a it's a challenge because they continue to be active and do things, and they always hurt themselves. So our job is not to get them out of pain. Our job is to help them enjoy a life that they want to live, right? And that happens to be pain. And if you focus at the very big root, don't don't get laser zoomed in on an injury. Don't talk about pain, don't talk about movement, don't talk about strength, don't talk about endurance. Let's focus on what is it that you do to help this person enjoy a better life, right? A life without the aches and pains, a life without those things. Let's focus on that. Okay, if that's the case and you keep that as your target, your job is easier. And when you determine whether you need taping or bracing, that's what's going to help you. So let me give you an example. If if you have a patient or an athlete, maybe they were in a gym, and maybe they do some type of functional fitness. Maybe there's plenty of types of businesses out there, F45, Orange Theory, these type of businesses where they're doing like group-based classes, or maybe they're doing their own individual thing, and they're squatting, and they feel a tweak in their back, and they put the barbell down, and they were hoping to be able to participate in a community style functional fitness competition with their friends, like a group of guys or girls, whatever it is, and they wanted to participate in these things. And it's in 3 weeks, and the patient feels a tweak in their back, and they're really scared. And they've seen you before, so they call the office, and they're like, "Hey, I want to see you, David. I want to be able to get in. You've seen me from my back before, and I tweaked it. Here's the problem: that I have a friendly competition with my friends in the next 2 to 3 weeks. Is it possible for you to see me today?" Absolutely, we'll get you in today at 4 p.m. Perfect. Get them in. And now you're in a scenario where, oh goodness, this is a fresh injury. This is not what I commonly see. I'm used to seeing somebody, 4 or 6 weeks, who has poor core stabilization, they have poor posture, blah, blah, blah. And this one's like, wait a minute, I can't even assess their posture because they won't even bend down to touch your toes, or they have a Gower sign as they come up from extension. And you're like, wait, I can even do my normal assessment. And now you can't even look at just the back. The question is, the patient's asking you is, hey, I want to be able to participate. I understand my back is messed up, but do you think I'll still be able to participate in 2 to 3 weeks? Now that question can stump you, because what they didn't ask is, what's the cause of my pain? They didn't ask, when is this going to get better? They didn't ask, well, is it my disc? Is it my sciatic nerve? They didn't ask any of that. So it took away your superpower. Your superpower is, well, let me see you move. Let me see how strong it is. Oh, they took all your superpowers away and they asked, how long oh, excuse me, how do you think I'll be able to participate and at what level? Man, that really takes PTs to another dimension. It really challenges our brain because we don't process like that. We don't think um, prospectively. We don't think, well, I'm very confident I can get you there. We think, let's just take care of it now. So, in this scenario, you have to figure out what other tools in your toolbox do you have besides movement and mobilizations that require a lot of active movement or corrective exercises. Now you're dealing with somebody who is um, very impaired and has a high pain threshold, and they can't tolerate a lot. And you're like, well, what am I going to do here for an hour? Now you have to figure out, okay, great. What's going to reduce my risk of them having flare ups, or what's going to improve my outcomes so they have the fastest outcomes to be able to get them back in the gym as fast as possible? And now these are different scenarios. And that's why I wanted you to zoom out and take the idea that we're going to manage their back pain. Stop thinking of that. Stop thinking of their hip mobility. Stop thinking of their hamstring length. Stop thinking about their psoas. Stop, blah, blah, blah. That's where we naturally go. Now I'm going to take all of your superpowers away and ask you, what else would you do if this patient can't tolerate your hands? They can't tolerate hip mobility. They can't tolerate stretching because they're so inflamed, and you just saw them day one of injury. Wow! Now that's a question. Can I even treat that? What do I do? Why don't I just let them rest for 2 weeks? Well, the challenge becomes, if you let them rest 2 weeks, what's the difference between you and the common association with, like, oh, a primary care would just tell them to rest for 2 weeks. Well, now you have that opportunity. What would change? If you had the dream scenario, you had somebody day zero, instead of saying that, oh, physicians, I've heard this before, that physicians, they just tell them to rest and they should just move. Great. Now you have the opportunity. Now they're flared up and they can't move. It just took away your superpower. What do you do now? Now you have to think of all their alternatives. So this all comes down to not just this framework or this case scenario, but ultimately it comes down to soft tissue healing. And this was the main topic. I asked the entire group. I think we just had 3 people register in the last 24 hours, a day after the event, and I think we have 38 sports PTs, chiropractors, PTAs, personal trainers, athletic trainers inside the group, with over 250 years of experience. And so it's great conversations. And I asked the group at the very end of it, I said, out of the first 2 hours of the course, what's your biggest takeaway? And 90% of the group said soft tissue healing. Soft tissue healing. That is the thing. So, I wanted to share how that relates to everything that you do inside your clinical practice now. How can this help you, even if you're not in the course? What can you take away that everyone else already has taken away with inside this course? So, let me get a little breakdown. Those who have had, taken my courses and things that I've done in the past, this is going to be a great refresher for you to be able to put this into context now. So we look at soft tissue healing. The first, let's go back to like old school physiology courses. The first 72 hours is the peak of the inflammatory phase. This is where, all of the repair processes, platelets, and everything are attacking things to either, stop bleeding or open wound, or if there's internal bleeding, or if there's damage and localized swelling. This is where everything is infiltrated in the first 72 hours. And that's why people's joints or certain body parts, they get inflamed. And so this is a point where you don't want to risk a lot of things in those first 72 hours. And as clinicians, we typically don't see this. Now, if you work in urgent care, you work in work very closely with somebody who does this, or you're an athletic trainer and you work very closely with high schools or people that you can get referred to quickly, that's great. So the first 72 hours of the inflammatory phase. The next phase is a proliferative phase, which starts from like day 4 to about day 21 to 24. So the peak of the proliferative phase is day 14. So inflammatory phase is at day 3, and inflammatory and proliferative is at day 14. And the reason why proliferative is peaked at 14, that's just the natural production of collagen and repair processes that come in that create, a little bit of the start of the scar tissue. And this is why, if you've ever wondered why, post-surgical wounds, it takes about 14 days for stitches to come out or heal or everything come together. That's what's happening. You're in the middle of the proliferate phase. You're like the peak of it. And once you get through that, the start of day 21 is when you start remodeling, right? This is what we consider like the chronic phases. And as you look at like the peak of the remodeling phase is around 28 to 35 days. So it's about the 4 to 5 week mark. And so this aligns with, post-operative care. We know that the first 3 days, you're really not seeing much people post-operative. They're such in big pain, and they're taking meds. And right around the 2 to 3 week mark is when you see them because they're finally getting their stitches out, those type of things. And that's when you start more range of motion and light activation. And then at 4 to 6 weeks, that's when you can start to push. It's all based on these three fundamental tissue healing guidelines. And so typically physical therapists, we only see people 4 weeks or after an injury because of the scenario that I started with at the start of this podcast. Most times you're not going to see them until they've gotten till the 4 week mark, which is they're at the remodeling phase. So as a clinician, when you see people and you're like, oh, I wouldn't brace or anything else, it's probably because you haven't seen them in the early phases and you're seeing them at remodeling. So they're able to move, they're able to do things. You can actually evaluate their posture and do all these other things, and they can do all of the corrective exercises that you want because they're out of the main two inflammatory phases and then proliferative phase. And because of that, I get that. That's why you don't use taping or bracing often. But now, what if you had a scenario where you had somebody in those first 0 to 72 hours in the inflammatory phase and you don't want them to re-flare it up or aggravate it, or you don't want them to fall or slip, or you see them in the first 14 days when they're in the proliferative phase and they're just starting the process to build collagen and actually have fibroblasts come and create scar tissue. So if that's the case, if they don't have the stability or balance, or that ligament is loose and it's not healed yet, why would you start corrective exercises when they don't have the internal stability yet? That would make zero sense. Think of a post-op. You wouldn't do that with an ACL. You wouldn't do that with the meniscus repair. You're going to attack it in a very slow progressive load potential. Now, the great part with post-surgical is that we have a lot of times physicians provide braces, hard braces, hinge braces, whatever that is. And that helps. That already gives us a guide. But now, what if you had to determine, gosh, I don't have a physician to tell me, let's assume this is not a fracture or anything bony pathology and not a complete tear. Now it's musculoskeletal and you can confidently handle that. It's the dream world. We want direct access, yet we don't have the skills or confidence to manage the direct access. So now what do we do? So this is now an easy way, an easy outline to determine what types of brace you would use and when and why. When we look at bracing has been shown to be effective in the short term with subjective response, not with actual tissue repair of the shoulder, the back, and the ankle. And when we look at bracing, there's two different types. There's a hard brace and there's soft braces, and there's hybrids, everything in between there. And so when you're looking at hard bracing, things are hinged or they don't allow a lot of movement, like an extension brace on a knee. When you have somebody who is injured and they have grade one, grade two ligament sprain or soft tissue injury or a muscle strain. So usually 4 to 6 weeks for grade one, and anywhere from 8 to 12 weeks for grade two. 6 to 8 weeks for grade two, and 10 to 12 weeks for grade three. And when you're evaluating these individuals, and if you see them early in those phases, when do you apply a hard brace? When do you apply a soft brace? Because we're not talking about somebody who's in the remodeling phase, who's 4 weeks out. We're talking about somebody who is very fragile, very sensitive, and their early healing phases are not complete yet. They're maybe at day 3, they're in the inflammatory phase, they don't want to move that leg. They're in day 14, they're peak proliferative, and they're now just entering the remodeling phase. Your exercises, your correctives are no longer usable until minimum 4 to 6 weeks until they're the peak of remodeling. So, because of that, what would you do for the first 28 days? What do you do at inflammatory? What do you do at proliferative? And at the start, what do you do for 4 weeks? What do you do for 28 days before they start remodeling? That's where this gets tricky, and you can't be with them all the times. This is why urgent cares and primary cares provide slings and braces, because even though you might say, well, it's better for movement, I understand, but they have to do this at scale. They think, is this person going to die on my clock? And if it's pure musculoskeletal, they'd rather just go safe with bracing it, stabilizing them, and then sending them out to somebody who can pay attention to them and work through and navigate, which is our specialty. Fantastic. The challenge is, what if you had to handle them right now on your own? Would you have that confidence? What type of brace would you use? Would you be stubborn and say, oh, bracing's not great? Yeah, for a post 4 week remodeling chronic pain patient. Well, we're talking about a different human. So, um, anytime that you're in the first 3 days inflammatory and up to the 14 day, because you're in peak of proliferative, is when you would use a hard brace, a protective hard brace, or a very stiff tape. So, for instance, athletic white tape or Leuco tape, these are very rigid tapes, or a hinge brace, where you have the most amount of protection. And once you get past day 14, this is why postoperatively, a lot of physicians or physical therapists will remove the brace at day 14, or they start to wean from it, or they change how much they're actually doing. Is it waking hours? Is it all sleeping hours? Whatever it is. It's only because of soft tissue healing, guys. It's not just because time has shown that it's effective. Well, the reality is that it's not just time or humans; it's our natural cellular process. So, if you know what the cellular process is, now you can provide actual days when you project it to wean from things, to discharge actual use of things, versus saying, "I don't think bracing or taping helps." Whoa. Maybe it's shown in the chronic phases. What about acute phases? There's plenty of research to show it does affect people's outcomes and their ability to return to sport faster, especially in ankles. So, when would you transition to a soft brace or a modified brace? After day 14 is when you can transition them up to day 28. So, say for instance, you've got a grade 2 ankle sprain. You can do a hinge brace or a very stiff ankle brace that doesn't allow a lot of inversion, eversion. That's great for the first 2 weeks. And then you can't keep them there because they're going to stiffen up and they'll lose a lot of motion. And then at day 14, you can wean them towards a modified brace. From there, when do you start to wean them from it? Comfortably at the 4 week mark at day 28. Why? Because they're just passing and entering the remodeling phase. So now you have progressions. You have 2 week blocks where you can go hard brace or tape at 0 to 2 weeks, modified brace with a softer brace or tape from day 14 to 28. And then from day 28, then you can be the sports PT inside the clinic like you normally do, and you never want to have anybody reliant on things. You want to make them independent, strong, and great movers. That's fantastic. But what I'm telling you is your methodology and how you practice in the clinic does not apply to the first 28 days. Why? Because they're sensitive and they're vulnerable and their tissue is vulnerable because they're just starting scar tissue formation because of their healing process. So, I titled this, when taping and bracing are essential for injured athletes. And it's not I'm not just saying it's regional based and here's the best brace for backs and here's the best brace for shoulders and knees. And I'll let you search on Amazon or, Donjoy or whatever, website that you want to find the latest brace. Because by the time you listen to this podcast, this is recorded in 2024. If you're listening to this in 2027, 2028, I'm sure there's a great, fantastic brace that just came out that's better than the one from 2022, right? So I think that, the principle is the most important piece here. Don't put yourself in a corner and pigeonhole yourself to an anti-brace or an anti-taper. Your role in this whole process is not the region, not pain, not movement, not coordination, not endurance. It's helping somebody enjoy the things that they love in life. And if this person, this case that I brought up, who has back pain and wants to participate with their friends in a friendly competition at a park or whatever it is, your job is to say, oh, I don't even think it's possible. I would just give up. If it's in 2 or 3 weeks, do the math. Let's assume it's in 3 weeks. All you have to do is get past inflammatory at day 3, past the proliferative at day 14, and now they have a week to actually move and get strong. So the question is, the response is that you can't participate. You're only going to have a week to really practice. Do you feel comfortable with that? Because I would put you in a soft brace, a compression brace, or some type of a brace around the low back, only for the first 3 days, and maybe start to wean you in those first 3 to 14 days, and then really just start working on core development. But I'm not doing a lot of movement. I'll get you past day 14. I'm only going to have a week to really put you underneath load or a squatting bar, and that allows you to project and allow confidence as soon as the initial evaluation. So when is taping and bracing needed? For sure, in those first 3 days, up to day 14, and you can start to wean or progress or work on modified things from day 14 to 28. And so if so, what happens if you don't do this? You know, our profession, and I'm a big proponent of this because I really think that we as a profession are going to shift in what services we can provide, especially in the outpatient ortho world. I can't speak for neuro or peds, and that's not my specialty. And my passion, my obsession, is sports PT, and I really believe that we are probably only using 20 to 30% of our total superpowers with what we can do for people who want to stay active and healthy in life. And inside my sports PT Kickstarter, I have 8 modules based on even what the sports section defines as sports PT, whether it's like modalities or direct treatment or all these other things, on the field care, strength and conditioning, injury prevention, wellness care. I mean, all these domains. And if we don't have confidence in all of those domains, we can't service our community members. If we stick to being a hands-on or exercise or corrective-based, movement-based PT, you're stuck in the clinic, and it doesn't allow us to grow our arms into the community. We can't work with urgent cares. We can't work with primary cares. Why? Because if our skill set is only from remodeling phases from week 4 to week 16, because that's when we see them post-op, you're pigeonholing yourself. You're in a corner that you can't service any other patients or athletes. Think about that. Your entire career is seeing people in chronic pain, typically from week 4 to week 16 after injury and beyond. If they have 3 years of chronic pain, that's just a small window of what we can do for humans and really make an impact in our community. This podcast was about what we can do for people in acute phases, meaning you know your grandma, your aunt, your uncle is going to sprain their ankle. The worst thing they can do is just like stabilize and do nothing. Your goal as a clinician is to figure out, okay, what if we stabilize? What else could we be doing to expedite their healing? Taping and bracing would be one adjunct, and it's just one extra superpower tool in your toolbox that you can be throwing into your cases that would just make the smallest difference. So rather than being stubborn and saying, I don't do that in the clinic, what if I removed you from the clinic and you were now in an urgent care or primary care office? You can't use that. You can't say that. How would you help these humans? Our goal is to help people enjoy life with less aches and pains and allow them to do the things they love. I didn't say use taping and bracing for pain management. I didn't say use taping and bracing for tissue inflammation reduction. I'm just saying allow them to do the things they love, and they might need this to supplement while they progress it back into the clinic. And if you feel that I'm getting fired up, I love this stuff because I truly believe that I've been exposed to this a large portion of my career. I'm not an athletic trainer for those who are on this. What are my credentials? I'm a single credentialed physical therapist, and my wife is a physical therapist and athletic trainer. And I had a lot of exposure to acute injury management. I went through the residency at sports residency at The Ohio State University, and It's where I worked with a lot of great, phenomenal athletic trainers and sports physical therapists who were SCS, dual credential, single credential, whatever it was. And ultimately, I really got to get a hands on experience for 3 years there and working with high schools and collegiate rugby and various sports. And you have to get your hands wet. You have to have that exposure. And then once I had that, I've traveled the world with United States Olympic Committee as their physical therapist and representing the world's best athletes. And I've traveled to, 10, 13 countries underneath them and multiple platforms, world championships, high level events. And there's just so many scenarios where I realized that this exposure is so critical, and the public doesn't know what a physical therapist is. If you ask what a physical therapist is, they're going to say, well, they wear khakis, a polo, and they give you exercises. That's what they think a physical therapist is. And I know we can change that perception. Our job is not necessarily just movement or exercise or pain management. Our job is to allow people to enjoy a healthy and active lifestyle without barriers, with less aches and pains, without restrictions. And because of that, I'm not saying you need to use tape and bracing for everything. You need to know when it's a time and a place. So when you service that same patient, you have to be able to service them full circle, not when they're just out of the remodeling phase. Now you are an incomplete sports physical therapist because you don't have that skill set. You don't have to be an athletic trainer. And if there's athletic trainers on here, there's amazing athletic trainers. And if you don't feel confident with this, you partner with them. You figure out how to work together because it's not about professional boundaries. It's about serving humans. How do you serve more humans with a skill set you don't do? You either figure out how to acquire the skill set or you find other people who have it and you work with them and you know that patient's going to benefit. And that is what creates a community of healthy individuals. That's what a sports physical therapist does. We don't just do exercises. Get that out of your head. And today, I just want you to understand you could be using taping and bracing for the three regions. And the fourth I didn't mention was it's also been shown to improve pain reduction in knee pain subjectively, but not tissue repair. In either case, if patients are able to feel better temporarily, especially in these phases, it helps them transition to more exercise based and progressive resistant exercise and those type of things. So, why am I doing it? Because your community deserves it. We don't have the full skill set, but all you need is a better understanding to get your foot in the door to be able to manage these people. So wherever you are, I hope that that helps. If you're listening to this in the second week of 2024, if you're interested in still attending my Sports PT Kickstarter, I'd love to have you on board. Go ahead and send me an email, drchris at drchrisgarcia.com. If you're listening to this recording after January, second week of January, you can also take the same Kickstarter course as just self-study. So it allows you to, it's the same modules. It's just self-guided. There's a lot of homework assignments. There's a lot of modules, and it's a little bit of a time commitment, but it puts you in a position where you're getting all the domains of a sports PT. So if you're interested, send me an email, drchrisgarcia.com, or if not, it is on my website, drchrisgarcia.com / Kickstarter dash self dash study. In either case, if you love this stuff and you want to continue to thrive as a sports physical therapist, consider joining my Sports PT Academy, where I mentor physical therapists once a month and keep them in a position where they're growing and thriving and not just listening to podcasts and really actually throwing this into their clinical practice. So that's for you. The Academy is the next step for you. You can find more information at drchrisgarcia.com / academy. Other than that, I hope you guys are thriving and enjoying life and absolutely crushing your patient outcomes and truly living your dream. All right. I will see you guys on the next episode. Take care.